Hi, everyone. We are going to go right into our next session, please. If everyone can find their seats, please, for our next session, Gastrointestinal Problems and CDKL5 and Rett-like Disorders.
Okay. Not getting on the screen up here.
So you're trying to get it up there?
Here, it's already up there. I think it's okay. Okay. What am I doing?
It looks like there's multiple.
I see.
Right here.
Oh, I see.
Dr. Liu, I'll be right back. I just want to tell everyone outside real quick.
Thank you. Okay, I'm happy to come up here and chat with you guys. We'll talk about GI issues and in CDKL5 and Rett-like disorders. And let me see if I can advance these slides. Okay, I've got nothing to disclose here, but we will talk a lot about poop today. This is going to be a very clinical talk, so if you have questions, feel free to ask afterwards, and I'll try to stick around. Okay, so when we talk about GI problems, you know, they're very common, right, in CDKL5 and in Rett syndrome. And this was coming from the British Owl Rett Syndrome survey that shows how common these issues are. So GI problems, at least in Rett syndrome, are second only to seizures, okay, followed by respiratory issues and cardiac problems. But when you compare that to like the database from the International CDKL5 Disorder Database, you know, it turns out that it's as common, if not more common, than Rett. So when you look at the North American Rett database and look at all the individuals who reported a GI problem, you know, the most common ones that we deal with are things like dysmotility, problems with chewing and swallowing, weight issues, growth, bone density, and a small amount with biliary tract disorders. The biliary tract ones are really probably related to gallbladder, like gallstones or sludge in the gallbladder. But how is CDKL5 different from Rett syndrome? So in general, you're going to see more GI problems in this condition than in Rett syndrome overall. And they found that the likelihood of finding GI problems really increased with age. But based on like the mutation group for CDKL5, there was really no major differences found. So when we look at the reported GI problems, so in this database, 86% of the individuals reported some sort of GI problem. And this is the way it broke down. So constipation and reflux, again, are the most common issues, followed by air swallowing and a number of individuals who required tube feeds. So this leads us to looking at the feeding difficulties that we see. And so 80% of these kids or individuals could eat and drink orally to some degree, but still about half of them would have trouble with feeding related to issues like swallowing or coughing. But when you broke it down, you know, only about 5% could actually eat or drink independently, and 35% could feed with some assistance. And that means, you know, 60% were completely dependent on assistance with eating. There were also 20% of the individuals that were exclusively tube fed. So when we talk about tube feeds, we're talking about either gastrostomy or G-tube or jejunostomy or J-tube feeds. And, you know, it was reported that 29% of the individuals in this database had a G-tube or J-tube. And the indications were related to feeding difficulties, poor weight gain, medication administration, or in general, just poor health. So what we're going to talk about now are just common GI problems in CDKL5 deficient disorder. And this is related to issues related to reflux, constipation, aerophagia, which is air swallowing, and dysmotility. Okay, so gastroesophageal reflux, it's very common. We all experience this, right? It's basically regurgitating contents in from your stomach into your esophagus, right? And the symptoms that someone has, I mean, for us, we feel heartburn. You can feel a lot of acid. You might get throat burning. But other symptoms you might experience would be things related to vomiting, rumination, which means you regurgitate up formula or milk or something, and then you kind of chew on a little bit, and then you swallow back down again. Respiratory signs, because food may go down the wrong tube, and sometimes even feeding difficulty that leads to weight loss. And so the complications that we may deal with when someone has reflux include weight loss, but also aspiration and esophagitis. Okay, esophagitis being irritation of the esophagus. Now note that we all have some degree of reflux, and it's rare for reflux to actually cause irritation in your esophagus, to cause disease there. But when it sits for a long time, it certainly can cause erosions. So why does reflux occur, though? So there's a few factors related to this. One would be that some people may have poor esophageal clearance of liquids. So when you actually regurgitate into your esophagus should actually squeeze and propel the food back down into your stomach. But when you're dealing with motility issues, sometimes the esophagus just doesn't do a very good job of clearing it, so the acid can stay in your esophagus and start to cause damage. You also have something called the lower esophageal sphincter, and that's the muscle at the base of your esophagus. And when someone has reflux, we know that oftentimes that sphincter might be incompetent, so that the muscle tone is very low, and so it stays open, so it's very easy to regurgitate food back from your stomach into your esophagus, or that muscle may relax inappropriately and just open when it's not supposed to. So normally when we swallow food, that muscle's supposed to stay closed, and when we swallow food, the food goes down, and then the muscle opens, the food passes, and then it closes again, all right? Or if we have to burp, a gas bubble comes up to the top of our stomach, the muscle senses it, it opens, relaxes, the air bubble comes up, you burp, and then it closes again, all right? And so the third factor that might be related to gastroesophageal reflux would be that you may have poor gastric function, okay? And when the stomach doesn't move well, then you may end up with a persistently full stomach. So you can imagine if you continue to have food in your stomach, it would be very easy to regurgitate it back up again. So treatment for a reflux. I mean, typically we use very conservative treatment, right? I mean, I don't think standard reflux precautions are going to usually work in this situation, but you do smaller, more frequent meals, okay? You might have to thicken up the formula if you're doing formula feeds. You kind of stay a little bit more upright to allow gravity to keep the food down. But beyond that, then we start talking about other medical therapies, and really the only other medical therapy we have is really acid suppression. That's using medicines like Zantac, Prilosec, Prevacid, to reduce the amount of acid in your stomach to protect your esophagus whenever you do regurgitate up. So keep in mind, these medicines, all they do is take away the acid. They're not necessarily going to stop the reflux, but the hope is when you take away the acid, if your esophagus is happier, it may just do a better job of keeping that food down. So if acid suppression doesn't help and we're dealing with a lot of reflux symptoms, then we have to be more aggressive with this. And the other options are fundoplications. That's a surgery, but that's not that common. We try to avoid it, okay? And sometimes we do tube feeds where we may put a tube past the stomach and into the small intestine, and this is called jejunal feeds, so that there's nothing in the stomach so that you won't be regurgitating it back up again. These are more aggressive measures when someone's dealing with significant reflux, but you should just hear about these things. Okay, so just so you know about what a fundoplication is, this is like an anti-reflux surgery, and so they would basically take the top part of the stomach where it meets the esophagus, and they make a wrap around the base of the esophagus. So this type of surgery is designed to recreate a lower esophageal sphincter. Okay, so it makes it tighter. And so this is only done if you can't control reflux medically and if you're dealing with significant complications. Like I said, this is something we typically try to avoid. But the advantages of doing this is that, well, if someone has significant reflux and you do a fundoplication, it could lead to a better weight gain because they're keeping the food down, but it won't necessarily lead to increased food intake. And the complications of this kind of surgery include a lot of retching, because if you imagine someone is used to burping up the food all the time, suddenly you close off that pop-off valve, then you can start to have a lot of retching. You can deal with bloating. You can deal with something called dumping syndrome that leads to diarrhea. But even more significant is that if someone's already dealing with potential dysmotility of the esophagus, it could lead to worsening swallow function because the esophagus has to now try to move the food past a tighter valve. So you always have to take extra precautions when you're thinking about a fundoplication to make sure that the esophagus is working well. Okay, so constipation is the other very common one. And so constipation, occurs when a colon moves too slow or when the anus isn't relaxing, okay, the outlet, or basically when you're just not completely emptying your stool. So, I wish I had a pointer here, but, this is just a picture of what the colon and the large intestine would look like. And this is something we need to monitor in our kids, right? And what do we look for? Because sometimes constipation can sneak up on us, and so we might not be able to recognize it. But look for firm stools, okay? If we're starting to have harder and harder stools, then they're not very lubricated and they're not going to be able to pass very easily. If we start having infrequent stools, look for large stools. So you may not have a bowel movement for several days, and then you finally have one and it's very large, the kind that would clog the toilet. These are signs of retentive constipation, okay? Constant soiling is a sign as well. So if you constantly have smears in the diapers, that might suggest that you're actually dealing with an impaction, okay? You can feel it in the lower abdomen too, usually on the lower left side. If you can feel a hard lump down there, then that may suggest that you're dealing with like a large fecal impaction. You may see streaks of blood in the stool, and someone may experience pain with stooling. So these are the kind of things you should be looking out for because we typically want to see bowel movements every day. Okay, so here's a Bristol stool chart. This is sort of what we use in the clinics to give you an idea for what a normal stool should look like. So, the top one, type 1, are like the little rabbit pellets, and that's the constipation type stools, all right? And the type 4, which are like the long sausages, are really what we expect. We like to see that, all right? But I think when we're dealing with lower muscle tone and we're dealing with neurologic disorders, and you may want actually softer stools, more towards number 5, maybe number 6, but basically going down to 6 and 7, that's diarrhea. So this is called the Bristol stool chart. We have like T-shirts and coffee mugs with this, and so it's probably a great Father's Day gift. Okay, so here's what constipation might look like if you imagined it, right? And so the way we treat this is you try to aim for daily soft stools, okay? And the goal here is to prevent retention of stool. So whatever you make, that's down in the rectum at the very exit, you want to evacuate every day, all right? And so basically, if the stools are too firm, you want to soften them, okay? We can use stool softeners for this. If the stools are too infrequent, then we use a stimulant laxative to try to make the colon squeeze better, all right? And if there's incomplete emptying, then sometimes you may require suppositories or enemas to keep the colon empty, all right? And certainly you're gonna always have some amount of stool throughout the colon, but when it's at the exit, okay, at the rectum, then that's, it needs to evacuate at that point. So here's a picture of what someone would have with really severe chronic retentive constipation, okay? So you can imagine the stool is moving down the entire length of the colon, but then when it gets towards the exit, it sort of gets stuck, okay? This is common. There's many reasons why someone may have retentive constipation, but in a situation with that much stool, this is what we would consider like a fecal impaction, okay? Like the amount of stool there is too big to get through the anus, right? And so typically though, you're not gonna deal with constipation this bad, but it can happen, and this is what we're trying to prevent. And so the management, the first thing is you got to make sure you get good fluid intake. That makes a big difference in keeping the stools lubricated, all right? Encouraging physical activity, and regular toileting habits if we can, okay? But otherwise, when we start using medications, the general classes are, the main one we use are stool softeners, okay? Things that sort of like draw water into your colon to make your stools as soft as possible, because if they're softer, they're basically slipperier and easier to pass, okay? If they're hard, then it's hard to pass. So things like Miralax, okay? All that does is draw water into the colon. Lactulose, magnesium, these kinds of things can make the stools softer, all right? But oftentimes, stool softeners aren't enough because you might make them soft, but we're still not stooling every day, all right? Just because the colon may be moving slow, we sort of retain it in the rectum. And so this is where using another class of medications called stimulant laxatives may help, okay? And stimulant laxatives are the kinds that make the colon squeeze. So one makes the stool soft, the other one makes the colon squeeze. And so the typical one we think about is X-Lax, right? X-Lax is the one, we throw in your brownies and makes you have diarrhea. Senna liquid is another version. It's just like X-Lax, and it makes the colon squeeze, so you get that extra stimulation. It really grabs your attention. You get cramping from this, okay? And then the last one would be like Bisacodyl or Ducalax, right? So these are the kinds that we may use as well. Now, oftentimes, in Rhett syndrome and CDKL5, when we deal with just kind of chronic constipation and slow-moving intestines, we use a combination of both, all right? So we certainly like to use the stool softeners, but not too much. We don't want excessive diarrhea, okay? But we do need to keep the stool soft, but then we like to add on a stimulant laxative on top of this. Now, keep in mind that one of the problems with using stimulant laxatives is that you can develop something called tachyphylaxis with this, which basically means when you use it every day for a while, then your body becomes resistant to it, okay? So the key is to not use it every day, and so what I typically like to use is a bit of Miralax or lactulose or something like that to keep the stool soft, and then I'll use a stimulant laxative maybe 2 days a week or 3 days a week just to encourage a good bowel movement. Now, sometimes if we really deal with like an exit problem, an outlet problem, this is where the suppositories may help, right? Because the stool may be sitting there at the exit of your rectum, and you're just not getting that stimulation. So using the suppositories, enemas may help evacuate just that last part of the stool. And rarely do we need to do like a manual disimpaction. So I'm going to refer back to this picture here because, again, this is an example of someone with a fecal impaction, okay? And if someone has that fecal impaction, again, you're going to feel that hard ball of stool in the lower abdomen, okay? And this is where you're going to get leaking constantly. And so someone may mistaken this leaking as having diarrhea, or just having regular loose stools and that we're pooping fine, but in fact, we're just getting a lot of leaking around the impaction, right? And the reason why this happens is because there's a sphincter. You know how we talked about sphincter in the esophagus? Well, there's a sphincter in your rectum as well, and it stays closed appropriately, right? But when you get a ball of stool that comes down into your rectum, that sphincter senses it, and it just relaxes, okay? And it allows that stool bolus to come on down until you recognize it, and then you go to the bathroom and you poop it out, all right? So if you can't poop it out, though, and that fecal impaction gets stuck in the rectum, then that sphincter stays open all the time, all right? And when it stays open all the time, this is why you keep on getting leaking, all right? And so, again, constant soiling is a concern that we may be having an impaction. Of course, if we're dealing with chronically poor rectal tone down there without an impaction, that's a different story, okay? But you do have to think about that. Okay, aerophagia, air swallowing. This is something that's actually relatively common as well, right? Maybe in about a third of our kids. And it's characterized by severe abdominal distension, okay? This is when you swallow a lot of air all the time. And this picture here is an x-ray of a lot of air in the stomach, okay? But once it's in the stomach, you're either gonna burp it out or it's gonna pass through the rest of your intestines, okay? And so the typical story is that your belly is very flat in the morning, okay? And then as the day goes on, it gets progressively more and more distended. And so, our kids will get very gassy. They can get very uncomfortable with this. All right, you may have a lot of burping. Okay, and usually the signs of air swallowing would be the repetitive movements, right? Your mouth, breath holding, maybe hyperventilation. These kinds of things may suggest that we're also having some air swallowing. So this is hard to treat, right? If we could do some sort of behavioral modification, treat the anxiety, because the anxiety can certainly make the air swallowing behavior worse, then we should do this. Okay, but otherwise you really got to prevent the constipation, because the only way the air is going to get through is, when they pass the gas. All right, gastric decompression. If you have a G tube, that can help, because you can keep that G tube vented so that you're automatically burping all the time. But keep in mind that once that air passes past the stomach, that G tube's not going to help you anymore, because it's got to make its way through the small intestine, through the colon, and you got to pass it out. So this kind of stuff, though, you can be very uncomfortable with it, but it rarely results in complications. Okay, so now we're going to move on to gastrointestinal dysmotility. Okay, so dysmotility can affect you anywhere in the GI tract, and dysmotility basically means kind of poor movement. Okay, you can get esophageal dysmotility. You can get gastric dysmotility, colonic dysmotility, or generalized issues. And esophageal dysmotility is something that, it's probably underassessed. And, obviously it can lead to difficulty swallowing. You can have feeding issues that are not related to the oral motor function. Maybe you'll get selective food refusal. So if you have poor function of your esophagus, you may prefer to drink liquids but not eat the solid foods. Provided it's not because you're having trouble chewing. It may lead to gagging and choking, and maybe more drooling if the dysmotility is pretty severe. So it can be hard to separate out issues between oromotor dysfunction and actual esophageal dysfunction. But there was one study, okay, this was in Rhett syndrome. They found that 75% of individuals with Rhett actually had some evidence of esophageal dysmotility, right? And there's different ways where esophageal dysmotility may take place. It's that lower esophageal sphincter, okay? Remember how we talked about that helps you for reflux? Well, sometimes it may just stay very, very tight, okay? So it doesn't relax, and so food has a hard time getting down. Sometimes the pressures in the esophagus are very tight. The muscles spaz, and it may make it difficult to swallow. And when you have dysmotility of the esophagus, it can, again, result in poor clearance of the esophagus, and so if you reflux, it stays there for a very long time and causes damage. But in other kids with other forms of neurologic impairment, you can also, besides having high muscle tone in the esophagus, you may also have low muscle tone. Okay, so it really varies, and the only way you can tell is by studying this. I can tell you though, if someone has high muscle tone, then that might be a little bit easier to treat, because you can try to use medicines to try to get that muscle to relax. If the tone in the esophagus is very low, then there's not much we can do about that. So treatment, if you have esophageal dysmotility, you got to treat any kind of reflux that's present, because if you have a lot of reflux injury, that may promote dysmotility. Okay, again, if the esophageal muscle tone is increased, then we can think about meds to try to help that. But otherwise, if you really have a hard time swallowing, then you really have to just bypass the esophagus for nutrition. And this is where we think about the tube feeds, okay, like gastrostomy tubes. Okay, gastric dysmotility. So when the stomach doesn't work, it's almost like it falls asleep on us. And this can lead to feeding intolerance. And feeding intolerance can look like feeling full very quickly, being intolerant to high rates of tube feeds or high volumes. You may have a lot of vomiting. You may have distension of your belly, more regurgitation, a lot of discomfort. Okay, and you may actually have a lot of backup of formula in the G tube if you're doing G tube feeds. So the way we try to manage this is that we use meds to try to speed up the stomach. And this is because we're assuming that the stomach isn't moving very well, okay? And so kind of medicines we use to speed up the stomach, they're not great, but you can try them. Erythromycin is an antibiotic, but when we use low doses of this, it helps promote intestinal motility. Reglan is another one that we can use, but there's always a higher side effect profile for this. Periactin or cyproheptadine is another one that we may try to help the stomach move faster. But besides the stomach moving slow, Sometimes this could also be a problem of the exit of the stomach being too tight. All right, and if the exit of the stomach, which is called the pylorus, is too tight, then it can look like gastric dysmotility. And if that's the case, sometimes you can even do Botox injections of the pyloric muscle to get it to relax so that food can leave the stomach faster. Okay. Oftentimes there may be a combination of both, and it can be hard to tell. Anytime we deal with motility issues, these things are just hard to diagnose, and you sort of have to just try them empirically. So when the stomach really fails, though, okay, if we really have a hard time feeding into the stomach, this is where we need to talk about tube feeds, right? And now obviously we've talked about G tubes, but GJ tubes are another way to feed. GJ tubes means gastric jejunostomy tube feeds, right? And basically, a lot of you may be familiar with it, but a GJ tube would be a tube that already goes into the stomach, and it can look just like a G tube, but there's an extra length that goes past the stomach and into the small intestine, okay? So you can either feed into the stomach or you can feed into the small intestine. And so this is one way to bypass the stomach if it's not working well. And so this would be a picture of one form of GJ tube, but it's a little bit longer, not that low-profile G tube that we're used to seeing. So there's like a port for the balloon, there's a port for the jejunum, which is the small intestine, and then a port for the stomach, okay? And in this situation, this might be useful for kids who have a lot of aerophagia, for example, where you might want to continually vent the stomach because they're swallowing a lot of air while still being able to feed them into the gut by going into the small intestine, right? There's a lot of different options we have. Okay, colonic dysmotility. So that means, slow transit of the colon. And, it has to be distinguished from like a problem of the outlet, okay? Another sphincter is at the end of your colon, at the rectum, okay? And so when someone has colonic dysmotility, it can lead to, constipation symptoms, right? You can lead to bloating. Sometimes it can lead to feeding intolerance. I mean, these are really just general symptoms, and it takes a lot of more detailed questioning to kind of figure out what we might be dealing with here. But the treatment, involves trying to treat the underlying constipation, but when you deal with significant colonic dysmotility, sometimes, maybe rarely, you need more aggressive surgical approaches. So what kind of tools do we have to assess the GI tract then? So endoscopy is one way, and this is to look for what we call mucosal disease, or disease affecting the lining of the esophagus, stomach, or small intestine. So we take that camera, when someone's sleeping, we put in the stomach, we turn on the lights and we look around and we take pictures and we take biopsies to make sure we're not dealing with acid damage or, ulcers in the stomach or other things like celiac disease or inflammation and things like that. Okay, and so on the bottom left would be a picture of the esophagus that would look nice and healthy. The middle one would be a picture of the stomach, okay, and then the bottom right picture is what the small intestine would look like. Okay, other things, actually I forgot to mention, a pH impedance probe is another tool that we can use. And this is something we use to assess for reflux. Okay, this is basically taking a catheter, a small wire that goes in your nose and it sits in your esophagus. And it can detect acid and it can detect liquid. So if someone's having a lot of regurgitation and with acid, we can pick that up and we can measure how much is going on over a 24-hour period, for example. It's not something we use oftentimes because you can tell when someone's having reflux problems, but if we're dealing with symptoms that may look like seizures or pain behavior that we think may be related to reflux, this is where doing like a pH impedance probe may help because when you notice it, you push a button and you record it, and then we see whether or not that's related to any significant acid reflux. Other things we may use to assess the GI tract, this one's called the SITS marker study. And so these are capsules that have tiny little markers in them that you can see on X-ray. Okay, and this is to look at colonic transit. And so we typically have 3 capsules. The day 1 capsules have 24 little O's in them, little O-rings. The day 2 markers have a line through them, and the day 3 markers look like little peace symbols or Mercedes symbols. Okay, and so this one's a little bit more challenging if you can't swallow the pills or if you can't put them in applesauce. But we've had families open up the capsules and kind of shove them into the G tube, to get into the stomach. But then what we do is we get x-rays. So someone takes a capsule on day 1, day 2, and day 3, and then we'll get an x-ray on day 5 and day 7. All right, and this is a look at how well these markers are going through the colon. And this gives us an idea for whether or not we're dealing with total colonic inertia, we're dealing with just kind of slow-moving colon, or if we're dealing with like a retentive constipation. So, for example, if you get an x-ray where all the markers have passed, as in the bottom right picture, then that tells you that the colon's moving pretty well. It's cleared all the capsules, okay? It's cleared all the markers. If you get a picture where, on day 5 and 7, all the markers are kind of distributed randomly throughout the colon, that kind of suggests to you that the colon's not moving very well and it's a little bit disordered in its motility. Or if you get the picture on the bottom left where all the capsules move through, but then they get stuck at the very exit, that gives you the idea that we're dealing with like a retentive constipation, okay? And that's more like an outlet problem where, using suppositories and enemas may help, for example. Okay, other tools, when we're worried about bad constipation, we may need to image the colon better. Okay, besides doing colonoscopy, we can do contrast studies by putting barium, as an enema to visualize the entire colon. It gives you an idea for how dilated the colon may be, how dilated that rectum may be. Okay, we could also do gastric emptying studies to see how long it takes for the stomach to empty. And then there's also other kind of studies that look at function like intestinal manometry, which uses catheters to tell us how well the colon's actually squeezing. So a lot of different things here. Okay, and probably the last thing I want to talk about here is pain behaviors. This is one of the most frustrating things. This is challenging because when we deal with pain behaviors, we commonly blame the gut, right? And probably for good reason. I mean, a lot of these things may be related to eating, may be related to stooling, but these are the things we think about when someone has pain behavior. Are we really constipated? Are we having bad acid reflux? Sometimes you may actually have bile reflux, okay? That's from bile from the stomach going up into the esophagus. Could we be having a lot of gassiness from air swallowing? Could we be dealing with poor gut motility? Could this be gallbladder stones or gallbladder dysfunction? What about pelvic floor disorders like anal rectal dysfunction, like an outlet problem, or even like a bladder problem? You can develop urinary retention from this. And then sometimes when you have pain behaviors, this may actually be related to dysautonomia, okay, like if someone may have like an autonomic flare. So these are always things to think about, and these are the common things that we consider when we get approached with a child that has a lot of pain behavior. So in summary, GI complications are common in CDKL5 and Rett-like disorders, and we have to be aware of these issues because they can certainly creep up on us. Reflux, constipation, aerophagia, gut dysmotility that can lead to feeding problems, and refractory constipation can occur. Dysmotility is challenging to manage, okay? We don't have good meds for this. Poor weight gain, tube feeds are a consideration, but there's a lot that we still don't really understand. So this is why I gave you a very broad talk about the common things that we deal with in the clinics. But that means there's a lot of opportunity for research in this condition. Okay, thank you for your attention.
Thank you, Dr. Liu. If we can we take a couple of questions? Do you mind if we take a couple of questions? Okay, yeah, sure. I saw one hand go up really fast, so.
Hi, I recently attended the International Academic Symposium for Integrative Medicine down in Baltimore, and one of the things they were really purporting as perhaps palliative but really effective in dealing with the GI issues was acupuncture, massage, and some of the alternative therapies. And I just wondered what your experience had been with that and if you found those effective. And they particularly were looking at the pediatric population with these.
So related to like acupuncture and integrative medicine type approaches, I never think they're a bad idea. It's worth trying. We don't have a whole lot of experience with it or a whole lot of data to say that this is going to be effective. If people have new data for this, that's great. I mean, I think it's always worth a try. It's always better than surgeries and, piling more and more medications. So we're not opposed to that.
My son has been on Miralax for probably 9 years now. I had read something several years back saying that extended time using this can cause further neurological issues. What is your experience with that? Would you recommend something different? Because if he's not on it, he does not have bowel movements, and he winds up seizing more when he's constipated. So we have to keep him on at least a small dose of the Miralax every day to keep him moving. God bless you, baby. But but I'm worried about causing any further neurological issues.
Yeah, that's a great question. We run into this question all the time, and there's actually a group that's really against Miralax, but we really don't have that data. Okay, I think there's been anecdotal reports where in someone who has a significantly leaky gut, it may cause problems, but there's just not enough data for this. And when someone can tolerate Miralax, not have any immediate issues for this, we're usually okay with using Miralax long term. Granted, we don't have that data, okay, but this is where you have to weigh the risks and benefits, okay, deal with major constipation and more seizures and other things versus treating the constipation. So this is something, yes, in general, we still use Miralax, when there's not enough data to support the evidence of saying that there's major neurologic problems with this, and I would treat the constipation.
Do you have any suggestions for kids who like to try and hold their bowel movements in?
Yeah, so stool withholding, that leads to retentive constipation, and that can get bad. It's very common in the young kids, and it's a behavioral thing. So stool withholding happens when you first pass a hard stool that gives you a fissure, gives you pain, and afterwards they're like, forget it, nothing's coming out of that bottom ever again. They clamp down, right? And so this is hard. The only thing you can do is keep the stools as soft and slippery as possible, okay? So eventually that fear and eventually that withholding behavior can go away. It'll start to evaporate, but this is where using the stimulant laxatives like X-Lax and Ducalax also help as a bit of a behavioral therapy because it sort of overwhelms the urge to hold it in, okay? So if you get it out as quickly and as painlessly as possible, then this may be the most effective way to treat this.
Hello, here. Using ketogenic diets in children, we have had complications on gastrointestinal issues. Do you have an alternative method, maybe using enzymes? Do you have any experience with that?
With the ketogenic diet, you mean?
Yes.
I think the constipation is really one of the major problems we run into with this. No, I think we have to... That's always challenging, and so there's a lot of other medications that can also slow down the gut, and this is where we work with the neurologist. And if the complications of treating the constipation are too bad, then we may have to reconsider the therapy that's being done. But when it comes to seizures versus constipation, I always lean towards getting the seizures under control. We can always find a way to treat the constipation.
Have you heard about the Strata procedure and if that has any benefit?
What is the Strata procedure again?
It is a procedure where they take probes and do something to the sphincter so the food doesn't come back up into the esophagus.
Okay. Yes, that's that would be like an anti-reflux procedure. I think it's done endoscopically, so the adults may do this, but. That would be more for adults. I don't have any experience with it in kids, okay? And typically they're still doing the fundoplication, but it is a consideration, and it may save from some of the complications of doing a stomach wrap, like a fundoplication, but you're still dealing with a tighter esophageal sphincter. So, when you're dealing with potential esophageal dysmotility, which may be as common as 3/4, of our kids, you have to remember that the esophagus has to squeeze that food down an even tighter sphincter, and so you worry that they're going to deal with even more dysphagia, difficulty swallowing.
I have a follow-up question to with the gal who had the child that holds in the poop. So I have a 16-year-old who's in just a dangerous pattern right now of holding. She can hold like you would not believe, and we are in a pattern of severe constipation. She's on 3 medications, the one that pushes, the one that softens, all of them. We go to the hospital for enemas because I can't even get it out with a home enema, and she passes, giant softballs worth of, and then if it goes too far, then of course the seizures get worse, and then she goes into all these dystonia movement. It's really, I'm wondering, someone had, like the Botox in the, esophagus. Do you ever have a procedure for like Botox in the anus? Would that
Yes.
help things?
Yes,
I'm
we
in a
do.
major-
So, yeah, exactly. Because some of this may be voluntary withholding, but a lot of this is poor motility and poor squeezing. And remember, when the colon gets that stretched out, it just doesn't do a good job of squeezing. Okay, so constipation promotes more constipation. So this is where medical therapy is failing, right? And you can certainly do enemas after enemas all the time to try to evacuate, but it's just not feasible to be doing this all the time. So yes, Botox is a consideration if we thought that the muscles were too tight. Sometimes the other surgical therapies we didn't talk about would be like cecostomy tubes, okay? It's like putting a G tube in the beginning of the colon, and then you can flush the Marilax through directly into the colon, and we do this every day to prevent the buildup of stool, okay? So there's other options that can be done. Botox is one, cecostomy tubes, those kinds of things.
I think we're going to have to stop, unfortunately, because we've got the next session starting. So in this room, we're going to thank you, Dr. Liu. Great job. So in this room, we're doing developing biomarkers and outcome measures for CDD research. And in the conference room 6, we like to move it, physical therapy for CDKL5. Don't make me say that again.
That's the power.
Oh, I'm sorry, conference 6.
I don't have a non-infectious
Sure.
motor